All right, welcome. Today we're doing something a little different. You're not just watching, you're in the hot seat. We're going to run through a series of rapid-fire clinical challenges in OB-GYN, and you're going to make the call.
I mean, really think about it. How do they do that? Well, a huge part of it is pattern recognition. It's about building this massive mental library of if this, then that. So the connections fire off almost instantly.
So consider yourselves scrubbed in. It's time to put that theory into practice. Your first patient is waiting. Let's do this.
Okay, we're going to start our rounds in the outpatient clinic. You know, the stakes are a little lower here, but your diagnostic skills have to be just as sharp.
Okay, first case. Patient comes in, she's got a single ulcer. But listen closely to the key detail here. It is painless. That's the big clue. What's jumping to the top of your list? If you said primary syphilis, you are absolutely right. That is the classic textbook presentation of a chancre. And that one word, painless, that's what seals the deal.
All right, let's mix it up. New patient, similar problem, but we're going to flip one single crucial fact. This ulcer is extremely painful. How does that completely change the game?
And boom, there it is, chancroid. Just by adding pain to the picture, the diagnosis completely shifts. See, this is that pattern recognition we were talking about, live in action.
Okay, next up, this is a big safety one. A teenager comes in. She gets migraines, but specifically, migraines with flashing lights. Now, that's your cue. That's code for a migraine with aura. So what type of birth control is an absolute no-go here?
He got it. Anything with estrogen. For patients who have migraine with aura, estrogen just skyrockets their risk of stroke. It's a major contraindication. So progestin-only options are the only safe way to go.
Okay, you're crushing it in the clinic. But now that pager is going off. Time to head upstairs to the delivery floor. Things just got a whole lot more intense.
You walk into the room. Your patient is 35 weeks pregnant. There's sudden, bright red bleeding, but she says she's not in any pain. There's that word again, painless. What are you thinking?
This is the classic picture of a placenta previa. And your very next thought, the one that has to fire off immediately, is no vaginal exams. Absolutely not. You could cause a catastrophic hemorrhage.
Okay, let's go to the next room. Same basic scenario, third trimester bleeding. But this time, it is paired with severe pain, and when you feel her abdomen, the uterus is rock hard. What's the call now?
Exactly. Placental abruption. This is a real, true obstetric emergency. The placenta is literally tearing away from the wall of the uterus. And once again, what was the pivot point? Pain.
All right, new situation. The baby's just been delivered, but your patient is bleeding a lot. You put your hand on her abdomen, and the uterus feels soft, kind of like a spongy, waterlogged bag. This is bad. What is your first move right now?
This is uterine atony. The uterus isn't contracting down like it's supposed to. So the first, most immediate action is simple. Firm uterine massage with one hand while you get oxytocin going with the other. You got to get that uterus to clamp down and stop the bleeding.
All right, deep breath. We're ramping up the intensity one more time. These are the code blue situations, the ones where you don't have minutes to think, you have seconds to act. This is all muscle memory.
Okay, this is a scary one. The baby's head is out, but the rest of the body won't deliver. The shoulder is stuck. This is a shoulder dystocia. What is the very, very first thing you do?
You have to follow the protocol, and the sequence is everything. You always start with the least invasive move. So, step one is the McRoberts maneuver, pulling her thighs way back to open up the pelvis. If that doesn't work, then you add suprapubic pressure from the outside. You only go to internal maneuvers if those first two fail.
You get called stat to a room. Your patient with known high blood pressure with preeclampsia is having a full-blown seizure. What do we call this? And what is the one drug you need to give, like yesterday?
This is eclampsia, and the number one priority is stopping that seizure and preventing another one. The answer is, and will always be, magnesium sulfate. Get that loading dose in immediately. Then you can stabilize and get ready to deliver.
Okay, for our final challenge, remember this. Knowing what not to do is just as critical as knowing what to do. So if you're treating postpartum hemorrhage, you have drugs to make the uterus contract. But if your patient also has high blood pressure, you have to avoid one of those drugs, or you risk a stroke. If she has severe asthma, you have to avoid another, or you could trigger a deadly asthma attack. These are those critical, if this, then not that connections.
And really, that's the whole point, isn't it?
That's what we've been practicing. It's all about building that rapid-fire mental library. Painless ulcer, syphilis. Painful ulcer, chancroid. Painless bleeding, previa. Painful bleeding, abruption. It's just a series of mental switches that, with time and practice, become second nature.
So you can take off the white coat now, but I want you to think about this. This idea of pattern recognition, it's not just for medicine. It's everywhere. In your job, in your hobbies, even in your relationships. So what are the hidden patterns you see? What are those tiny details that change the whole picture for you? Think about it. Thanks for playing doctor with us today.